this is the second in the series of 4. You may want to take a moment to jot down the dates of the next 2 sessions next week, covering throat and airway emergencies and key ENT procedures. Okay, so to go over what we're going to cover then, we are going to talk about acute rhino-sinusitis, periorbital cellulitis, epistaxis, nasal trauma, septal perforations, and then we're going to go through the interactive cases to summarize the material covered. So let's go straight in with acute rhino-sinusitis. So this is very common. It is mostly managed in primary care by GPs. It does have a significant impact on quality of life and also economic loss through time off work. It is also a very large source of excess prescribing of antibiotics, when in fact the etiology in most cases is viral. And it's defined really, so there's a lot of excellent information about this in the EPOS guidelines, so EPOS. If you Google that and look in the journal Rhinology, there's a whole lot of information there, but briefly, it's defined by 2 or more of the symptoms, of which one at least has to be nasal blockage, congestion, obstruction, or discharge. The plus or minuses there are the other symptoms that can be included, but one of them must be the ones from above. And that's in combination with, it must be symptoms, but also signs, either on endoscopic examination, so be that polyps, discharge or edema, or changes visible radiologically on a CT scan. So symptoms plus one of or both of endoscopic signs or CT changes consistent with ARS. So the red flags, really, the things that you want to look out for, which are the sort of dangerous complications, are given the location of where this is, as if the infection were to spread into or around the orbit, and you're getting periorbital swelling or redness, and of course neurological complications as well. So any altered consciousness, seizures, focal neurology are all things to be looking for actively, and of course, like any infection, signs of sepsis, particularly in the case of fungal complications. And what do you do really, of course, with these sorts of complications? They ought to be admitted, started on IV antibiotics, and symptomatic management. So painkillers, decongestants. It's important, of course, that the decongestant timing is sort of monitored. It shouldn't be given long term because of complications associated with that. It should be a short defined course. Antibiotics, as we've said, are sort of for sinusitis generally overprescribed, given that most cases are viral, but of course it is needed in bacterial cases. The NICE guidance, so the UK guidance for how to manage this in primary care, is that really we don't give antibiotics if the symptoms, if it's uncomplicated and the symptoms are lasting under 10 days. But of course, if it's lasting longer or there are signs of complications, then antibiotics ought to be given. As with most things, of course, the antibiotic of choice depends on your local guidelines, depending on local patterns of resistance. And intranasal steroids, of course, will dampen down the inflammation as well. But again, that is to be given after 10 days of symptoms. So let's just talk a bit about the complications then. So we mentioned already periorbital cellulitis. So this is what you might see. It is an emergency. It can be sight and life-threatening. It is more common in children, but you do see it in adults. The common bacterial causes are ones that we might find on the skin, like Staph aureus, or respiratory sort of pathogens like Strep pneumoniae. And it can be primarily from the sinuses, or indeed complications from sort of the skin, so insect bites or or previous surgery. And of course, the other cause can also be teeth. So it's another thing which is important to evaluate when you're seeing the patients. The way of evaluating this or one way of evaluating it is using a Chandler's grading system. So there are 5 different levels. So pre-septal cellulitis is limited anterior to the orbital septum. The second stage is where it's progressed posteriorly, but it's still a cellulitis, so not a collection as such. The third classification is where there is abscess, but it's limited to be under the periosteum. The fourth layer, getting a bit worse again, is where there is abscess not limited to the periosteum, so it may be in amongst the extraocular muscles. And finally, the kind of most serious complication, cavernous sinus thrombosis, is you may well, or are in fact probably likely to encounter cranial nerve palsies on testing the eyes, and it has a fairly high morbidity rate, and obviously needs to be taken quite seriously, and close collaboration with hematology colleagues about the role of anticoagulation in such cases. And similar to before, things to look out for largely are eye signs, neurological signs, and sepsis. So the things to sort of actively evaluate really are, as we've mentioned already, the eye movements, look for any cranial nerve palsies, proptosis, which may be suggestive of a collection, pushing the eye forward, visual acuity, looking for any signs of compromise of the optic nerve, and color vision, again with compromise of the optic nerve. One might anticipate getting loss of red saturation in vision, and fundoscopy as well to evaluate for any papilledema suggesting neurological involvement. Of course, you want to have a look in the nose as well, look for any signs of discharge coming from the osteomeatal complex, and an assessment of the cranial nerves generally, as well as the eye ones. The indications for doing a scan are if any of those signs are positive, so it looks like there is evidence of compromise to the eye, or indeed if you can't assess it clinically, then you need to assess it radiologically. And even in those patients who may not meet those criteria initially, if there is failure to improve on initial treatment, that would be another indication again to consider a CT scan of the orbits and sinuses. And I mean, we've largely gone through this really. These are the things that you'd be looking for that would make you concerned. So we've mentioned already they'd be admitted and started on IV antibiotics. Again, the choice of antibiotics will depend on local antimicrobial guidelines, general supportive treatment, and decongestants to try and open up the sort of natural drainage pathways, and steroid nasal drops to reduce the inflammation. And in those cases where there is evidence of abscess, there are different ways to approach it. They can be either open approaches, so externally via a Lynch-Howarth incision, which is what's shown here. Most cases are, where there is a collection, most of them are medial along the lamina perforatia, which is the rationale for this sort of approach. But another approach is endoscopic, and I think the choice of these will largely depend on surgeon experience. And the nature of where the collection is. Okay, so let's move on to epistaxis. So probably one of the most common calls that you'll receive whilst on call. So common mainly in children and older adults, but of course can present at any age. In most cases, simple first aid will suffice, but there are cases where that is not true, and it can very much be a life-threatening emergency, particularly in patients with coagulopathies or who are taking anticoagulants. Just to review really the risk factors. So anything that dries out the nasal mucosa, so for example, the use of nasal oxygen, but also just depending on the ambient air. Of course, having anticoagulants on board will increase the risk, as will sort of local trauma as well. There are special groups of patients, like patients with HHT, who are obviously very much more at risk due to the fragility of the blood vessels there. And in terms of the anatomy, lots of the anterior bleeds come from Little's area, demonstrated in the sort of circle on the anterior nasal septum here. And of course, this site is actually a confluence of blood vessels which ultimately originate from both the internal and external carotid artery through different tributaries. So many of the anterior bleeds, of course, we can manage simply by simple silver nitrate cautery to the sort of responsible vessels on Little's area. So having a systematic approach is key. The first priority, of course, is to protect the airway. These patients, if they're bleeding profusely or bleeding for a while, may have large clots. It's important really to get those out, in order to be able to see what you're dealing with, but also, of course, to protect the airway, which is your first priority. Establishing venous access and bloods, of course, to evaluate them medically, but also the propensity to bleeding. Okay, so here's a suggested stepwise approach. So essentially starting with simple things first with first aid, pinching that sort of anterior soft part of the nose, leaning forwards, ice packs to try and get some vasoconstriction. And if that's not working, the next step up is silver nitrate cautery plus or minus adjunct. So that may include things like cotton wool with some adrenaline on, for example, applied to the area to try and slow it down enough to be able to see a vessel to cauterize. If it's simply coming too fast and you can't safely do that, then the next step up would be anterior packing. So, for example, using a rapid rhino, which they come in two sizes, an anterior pack and a posterior pack. You may well end up needing to do both sides. In addition to coming to posterior packing, if it seems like the bleed is coming from further back, in addition to the long rapid rhinos or equivalent packing solutions, you can use Foley catheters, which are passed sort of along the nose until you can see them at the back of the mouth. You inflate the balloon and then pull it anteriorly until it elevates the soft palate to sort of seal the nasopharynx, and then packing with BIP coated gauze, and then clamping that, taking care to protect the nose from any pressure damage. And if none of those things are working really, then the next sort of step up is surgical intervention. In those cases where they haven't need to be admitted with packs or such like, perhaps they've just had some cautery or even first aid measures have managed it satisfactorily, then things like Naseptin or Bactroban cream can be very helpful in moistening the mucosa and reduce the risk of it cracking and bleeding. So a typical regimen would be for 2 weeks. It's important, of course, to note that Naseptin contains a peanut extract, so it's always important to ask patients about that. And if they are allergic, to use something like Bactroban as an alternative. And conservative advice, of course, so anything that involves steam getting towards the nose, so hot food, hot drinks, hot showers, all of those things ought to be advised against. And similarly, any physical trauma like picking or blowing the nose for a minimum of a couple of weeks, really, but ideally in the long term. Right, nasal trauma. So again, like epistaxis, a very frequent presentation whilst on call. And in such cases, of course, you're called about the nose, but one always has to have in mind that nasal fractures are often in the context of head trauma, and therefore a priority is evaluating for head injury. With regard to the nose itself, there are a couple of things you want to look for. One is a septal hematoma, so that's a hematoma, collection of blood underneath the mucosa on the septum. The risk of that is that if it's left untreated, multiple things can happen. So one, you can get loss of blood supply from the mucosa to the cartilage, so you can end up with a septal perforation, or indeed it can be a focus for infection. And it's important to identify it and deal with it as soon as possible, really. We've already said about the importance of evaluating for a serious head injury, given the context that these injuries usually occur in. The other thing, of course, you want to look for is any evidence of a CSF leak due to the risk of sort of ascending intracranial infection and managing associated epistaxis. So you can see some fairly dramatic pictures here of some nasal fractures. So typically you want to give some time for that initial swelling to settle down. And really the nasal bones should be mobile for up to 2 weeks after the injury. So typically seeing them between sort of 5 to 14 days in the ENT clinic is what we'd usually do. And very often if it's sort of grossly displaced, a solution is infiltration of local anesthetic and then manipulating the fracture back to a satisfactory position. Once, of course, you've checked for all the other things that we've already mentioned. Now, this is sort of an example picture of what you'd see in a septal hematoma. They look just like a sort of red swelling. You can't say with certainty if you see it on one side or both sides. Like it can present as either, actually. So of course it's important to check both sides. And this is kind of just a cross-sectional diagram here showing you this collection of hematoma adjacent to the septum there. As we mentioned, one of the main risks is that static blood is actually a focus of infection, and so it needs to be drained. And again, as we mentioned, the other risk is a risk of perforation of the septum itself, and you can end up with things like this, which is called a saddle nose deformity, where you have loss of the cartilage because that mucosa, which gives it its blood supply, is stripped off by the hematoma pushing it away, and so you get nasal collapse, which is a bit of a disaster, really. So coming on to perforation, so here's a picture of what one might see. I mean, this is a fairly small one. They can be much larger. The presentation, it says here, is epistaxis, of course, and that's because you have that communication between both sides of the nose, and in fact, dry air passes across both, which dries out the mucosa. So particularly the kind of posterior edge of the perforation is where you might ordinarily expect epistaxis to be coming from in these cases. Because the air is passing through as well, they get annoying whistling noises, which patients often find frustrating. A nasal obstruction, that's because you've got air passing there. You can get inflammation and a buildup of crusting around the perforation, which can make you feel like your nose is blocked. You can see on the scan here absence of the septum there. The differential is quite wide, and I'll not kind of read through them, but you can, thinking about the patient you've got in front of you, are they reporting or are they at risk of any of these differentials? Of course, the large majority actually are idiopathic and we don't find a cause. But it can be a presentation of serious disease like vasculitis or even a local malignancy. So it's important to rule out any of those causes before it's attributed to being idiopathic. And investigations really are targeted to the causes as you see them. So there is not really a strong or rather practice is very varied as to how to approach this. So you really want to tailor your investigations to the patient in front of you. But probably at a minimum, lots of people would consider doing a biopsy to exclude any malignant process and a vasculitic screen, really as probably a minimum. So the management, as we've mentioned, a lot of the problems with this come from the fact there's dry air passing through the perforation. So ways to mitigate against that are to apply some jelly to just protect the mucosa. It's obviously quite awkward to be able to apply that. and it can be quite a challenge. For the crusting, saline rinses work very well, simply to wash those out. Other approaches, what you can see in the picture here is what's known as a septal button. So it's essentially a synthetic material which comes as a sort of fairly large sort of two circles joined in the middle, and you cut them to the size of the perforation and fit them in place. And they simply stop the air from passing from side to side. So they protect the mucosa, stop it drying out, stop the bleeding, stop the crusting. In cases where that is not a suitable option, so particularly if patients find that they're sort of rubbing or irritating, or they don't want them, then a range of local mucosal flaps are also an option for reconstruction of the defect. Right. So that's the sort of notes, as it were. So I'll pass you back on to Ben for the interactive cases.
All right. So yeah, now we're going to run through some cases just to put all of that into practice. So I'm going to share the poll for those of you who weren't here at the start. We're using the polls in Zoom to collect your responses. I'm going to give you about a minute or so once we've gone through it. So we've had a 32-year-old lady present to A&E with a nosebleed that's not stopped after putting cotton wool up her nose. Got a past medical history of asthma, hay fever, and peanut allergy. So yeah, if you open up the poll, you should see some multiple choice questions to run through. So what your first line management would be, a little bit of anatomy that we kind of covered right at the start, and having a think about what discharge advice you'd be giving. And this is all anonymous, so there's really no harm if you get it wrong or if you're not sure. So as I say, I'll give about a minute. We've had 10 people so far, so keep them coming in. Perfect. So final 10 seconds. You can see the answers flying in. All right, and I'm going to share the results with you. The big thing with nosebleeds is just having a clear kind of stepwise plan like we went through before. So the first line is a good pressure on the nose. So it's in the right part of the nose, so squeezing that soft fleshy bit of the nose firmly, staying upright to protect the airway, and taking it from there. And then all these kind of other steps are options, but for the vast majority of people they won't be needed. Then running through, so in terms of the anatomy, there's a little bit of a spread of answers. So a slight trick question, which almost half of you kind of spotted, is it's that inferior labial artery is not
part of Little's area, and in fact is supplying the lower lip.
Down to the mouth, not up to the nose. It's the superior labial artery that goes up to the nasal septum. And then in terms of what wouldn't be your discharge management plan, again, bit of a trick question, but essentially just hammering home, always ask about peanut allergies. So as to 3/4 of you said, you don't want to give someone with a peanut allergy an Septal to take home. Alternatives would be Bactroban, like we talked about, or kind of other antiseptic creams. And the other stuff is sort of part of your routine advice. So you always want to make sure people have got good first aid advice, because as we sort of said, that firm pressure at home, you don't really need to come to A&E if you've done that and it's stopped in less than 20 minutes. Avoiding blown nose, picking nose, again, just trying to stop rebleeds, and avoiding heat essentially for 48 hours. All right, so then we'll move on to case 2. So this time we've got a 26-year-old man presenting to his GP with a 4-day history of nasal obstruction, green yellow discharge, and facial pain. So very, very common for the GPs out there. All right, so I had about half of you, so final 5 seconds to get your answer in. I'm going to end it there and share. So almost everyone, yeah, this is sort of, it's a 4-day history, so saying acute rather than chronic. And so that's the big one. Septal abscess tends to follow kind of trauma, and I guess you'd have to be looking in the nose, but there's nothing really to indicate in this guide that that's what's going on. although examining is obviously a good plan. And then
let's just work through the management of this.
So simple analgesia should be part of your plan. So that's the mainstay of treatment for these kind of acute viral rhino-sinusitis. So paracetamol, ibuprofen. And then he's only had it for 4 days. So as sort of a third of you pointed out, actually, seeing as it's a short course, you tend to start intranasal steroids if it goes on past 10 days. And the same with antibiotics. Intranasal decongestants would be reasonable for symptomatic relief. They don't have any effect on duration of symptoms. But the important thing to tell patients is they shouldn't be using them for more than sort of 5 to 7 days, definitely not beyond a week, because there's then a risk of getting rhinitis medicamentosa, where you then start getting discharged because of the medication rather than actual infection. So make sure if you do use decongestants, just to keep it short. We'll move on to the next one. Alrighty, so this time we have a 72-year-old lady who's been referred to ENT with recurrent epistaxis and a feeling of nasal obstruction. She's got past medical history of hypertension, and you've had a look in her nose, and this is what you can see. So again, you're going to have about a minute, so about 45 seconds from now. All right, final 5 seconds to get your answer in. And I'm going to end it there and share the result. So quite 50-50 on the nasal cavity. Now, this is actually quite hard, to be fair. So things to think about, I guess. So this is actually a septal spur, which is making things a bit difficult. And you can kind of see under here, we're looking at one of the turbinates. And I guess this growth with the eye of faith, you can see it sort of growing out from that lateral wall. So this is the left nose. Obviously easy when you put an endoscope yourself. And then top diagnosis, so quite a tricky one. And it's between these top two popular ones, really, with the kind of appearance of it. So 2/3 of people have gone for an inflammatory polyp, and 16% have gone for inverted papilloma, which we'll see more in part 2 of this case. But yeah, that's sort of where, particularly with it growing out the sinuses, what you kind of want to be worrying about. Chronic rhino-sinusitis, I guess you can get polyps with. So depends again on whether this is a normal polyp or an inverted papilloma. And then nasopharyngeal SCC, it's sort of right to be worrying about that. This is an old lady with a unilateral polyp and bleeding, which is sort of fits that 2-week referral criteria for possible head and neck cancer. So stage 2 is that you've got a scan. So you're going to see the result of that now. So this is the same lady's been referred in, and you've decided that you're a bit worried about that polyp and that you want to get a scan. So what scan have you requested? What plane are you looking at? And can you spot the abnormality? About a third of people answer in, so another 20 seconds or so. Right, I'm going to share the results. So a little bit of an uncertainty about the scan, I guess, depending on what we're doing. So we're looking at an MRI scan here. As almost everyone said, yeah, this is a coronal section. So cutting down kind of that way, looking across the sort of nasal cavities. And again, vast majority of people spotted it. So I don't know if Michael, if you can circle around the mask just so people can see, but yeah, that's sort of this inverted papilloma growing out the maxillary sinus, and you're seeing that polyp sort of protruding through is what you're looking at. So inverted papillomas tend to be benign, although they do have they can be locally invasive, as you can see here, so eroding away bone locally, and they do have a risk of malignant transformation into an SCC. But unfortunately, because this kind of slow growing tends to be quite non-specific, presentation often caught quite late. So this is a 34-year-old lady who's presented with a painful, swollen right eye. We found well, blocked nose for last week, and we've got a past medical history of rheumatoid arthritis. So what would you grade them on the Chandler's grading, which is a bit of a giveaway about the diagnosis? Do you want to admit them, and what treatment would you want to start? See, just over half of you have got your answer in, so final 10 seconds. All right, I'm going to share the results now. So, a little bit of uncertainty about the grading, which is understandable. So, actually, it's quite a swollen eye, but if you look, it's just the eyelid. It doesn't actually spread above or below the eye. So, this is actually grade 1, so it's pre-septal. So, there's no spread of the infection. Yeah, I guess the way to be 100% is when you then, if you have imaging, but off the face of this, it's just eyelid, no extension. And then management, everyone's kind of bang on. So do you want to admit this patient? Yes, worrying there's obviously a risk of permanent loss of vision if periorbital cellulitis isn't treated properly. And the patient's becoming very unwell and septic. So you want to admit them and treat them properly. And as pretty much all of you said, IV antibiotics would be sort of, yeah, a good starting point to see how the patient does. Oral steroids tend not to be used here, so it's more of treating infection, so rather than anything else. And now we're going to see part 2 of this lady's case. So unfortunately, she's had 24 hours of IV antibiotics, but the swelling was getting worse. She's still spiking fever, so you've decided to do a CT scan. I've given away the first answer. But so the other parts, what can you spot on the scan, and how would you grade it now? So that's about half of you have answered, so another 10 seconds or so, then I'll share the results. All right, I'm gonna end it there. So a few of you didn't hear me clearly say it was a CT head, so didn't give the game away fully. But yeah, this is a CT head, so most of you are right. Plain film X-ray doesn't really have a place in assessing sinusitis, and PET CTs largely in the realm of looking at tumours. So it's CT head, and we've got a couple of films. In terms of the abnormality, which gives away the grading if you remember it, a third of you, just over a third of you got it right. So it's tricky. So this is actually a subperiosteal abscess. So if you, I don't know if Michael wants to point to it with his mouse, but you can see it's kind of in that medial bit that we were looking at before, where they often are, and you can drain with a Lynch-Howard incision, and it's not quite. So it's quite a large subperiosteal abscess. So it's, I guess, heading towards stage 4 of an orbital abscess, but it's not in between. It's sort of under the periosteum and not involved in the extraocular muscles. Cavernous sinus thrombosis, we're not actually looking at the sinus, can't see the sinuses in this film, but there doesn't appear to be sort of marked proptosis or kind of backflow. And yeah, it's infection or tumour. And then the grading, I guess, comes into whether what you thought it was. So subperiosteal abscesses would be a grade 3. Grade 4 would be an orbital abscess. So yeah, and grade 5 being the cavernous sinus thrombosis. So moving on to the next case. This is a 43-year-old lady who's come to see her GP with current symptoms of nasal obstruction and mucky discharge, and she's got a past medical history of asthma. So what do you think you're looking at? What's causing it? What treatment do you want to start? And do you think she needs to rush to the ENT casualty clinic? So that's about half of you. So I'm going to give another 10 seconds and then I'm going to end the polling. All right. So I'm going to share. It's a little bit of a spread of confidence on the first one, probably. So in terms of where we are, so this smooth wall on the left is the nasal septum. And then you're looking at the turbinates, these two structures. So that bottom one's the inferior turbinate, and then just above that, looking at the middle turbinate. So this polyp is lying on the floor of the nasal cavity. So seeing as it's under the inferior polyp, so we call that the inferior meatus, and we're looking at the left nasal cavity. Again, a lot easier if you put the endoscope in yourself. So then in terms of diagnosis, I've understandably stressed, it's difficult to distinguish between inverted papillomas and inflammatory polyps, and we've just seen inverted papilloma. Looking at this, I guess it's a bit smoother rather than kind of craggy, but it's quite tricky to set apart. So this is an inflammatory polyp rather than anything else. And then in terms of treatment, so no kind of evidence of infection as such. Intranasal steroids are the thing to start in someone with chronic rhino-sinusitis with polyposis, and as sort of a first line, starting intranasal steroid. Surgical resection, so functional endoscopic sinus surgery and polypectomies might come in, but they tend to be sort of further down the line after you've initially tried medical management with intranasal steroids. In terms of whether they need to be seen in the emergency clinic, so not in the emergency clinic. So this lady doesn't have any kind of red flag symptoms. She's not got acute infection, doesn't have red flags for a 2-week wait cancer referral, because no kind of bloody discharge, just got mucky sinusitis discharge. So it would be reasonable to refer to ENT, but not to be seen sort of the same day or anything. This is a 52-year-old man who's presented to his GP with persistent feeling of nasal obstruction, and you've had a look in his nose, and this is what you can see. All right, final 5 seconds. I'm going to stop it there. So yeah, pretty much everyone. Yeah, we're looking at a septal perforation. I don't know if you want to point to it, Michael, with the mouse. Yeah, it's that kind of black area. And most people got it, yeah. So it's type 2 diabetes, doesn't have a relationship with septal perforations, although there's lots of possible causes. So trauma being very common, nose picking, nose surgery, nasal cautery, various kind of rheumatological conditions, so granulomatosis of polyangiitis, rheumatoid arthritis, and then sarcoidosis, or infected things, so syphilis and TB can both cause it. And does it need to be seen at ENT emergency clinic? So not in the ENT emergency clinic. There's no kind of acute, so things that could be started if he's in primary care. So if he's symptomatic with the obstruction, we talked about it's kind of conservative things, so saline rinses or aquagel, so kind of lubricating the nasal septum. And then referring to ENT certainly, but it would be a routine referral to a clinic where surgery versus conservative management can be discussed. And certainly some of these screening bloods could be sent in primary care, I guess, whilst awaiting a referral, but there's no real emergency to happen. So second last one here. So this is a 25-year-old man who's attended A&E with dramatic eye swelling, as you can see. He's usually fit and well, and a keen boxer. He's had a painful nose for the last week since his fight, and noticed some smelly discharge over the last few days. So what do you think's happening, and what might have caused it? All right, so a third of you've got your answers in, so another 20 seconds or so. Final 5 seconds. I'm going to share the results. So yeah, most of you got it right. So cavernous sinus thrombosis, because you've kind of got a block of the venous drainage, so you get real venous back pressure, hence the kind of swelling around the eyes. Relapsing perichondritis is actually tends to present with kind of appearances of sort of cellulitis and those kind of swelling. So a bit of a red herring in this context, doesn't affect the eyes. And what might have caused this? This is a little bit cryptic, but yeah, just about half of you got my chain of thought. So he's a boxer, so having nasal trauma and at risk of developing septal hematoma. If they're not promptly drained, then they're at risk of getting affected. And then if you've got septal abscesses, the nightmare scenario would be then getting cavernous sinus thrombosis. So it's really just to remind, if you've got nasal trauma, have a look in the nose and make sure they've not got a hematoma, and if they do, make sure it gets drained. And this is just to make the point of the triangle of danger or death, if you want to be dramatic. But essentially, it's the part of the face that's got venous drainage going back into the cavernous sinus. So it's really just to worry about infections in this region. If someone's kind of got, so the reason to worry about septal abscesses is just that you've got that tracking back into the intracranial space. And then the final question. So I had a 14-year-old girl referred to ENT with recurrent nosebleeds. She's got no other bleeding symptoms, normally fitting well. And you've had a look in the nose, and this is what you can see. I'm going to share the results. So yeah, most of you right. So hereditary hemorrhagic telangiectasia. So one of the rarer causes of recurrent nosebleeds, but tend to first present in kind of teenage years. So right around this girl, and recurrent epistaxis is often one of the first presenting symptoms. So then in terms of investigation, so tend to not want to prod these things, so there's high risk of bleeding. So rather than biopsy, it's this MRI head with gadolinium is sort of one of the next steps. So the hereditary HHT for sure. The risk is that you can get arteriovenous malformations in various organs around the body, so including the brain, lungs, and GI tract. So it's really screening for the arteriovenous malformations and sort of referring on to make sure that they get sort of the appropriate treatment for all their kind of whole health needs. So yeah, one of the rarer ones, but worth having in mind in younger children.
Okay, so that's the session. We're going to stop the recording there and take any questions. Thanks for listening.